Good afternoon, everyone. Sarah Glenn-Smith, the chairwoman for the Mass Commission. I was appointed by Senate President Spilka. Thank you all for coming and meeting with us.
Thank you so much. And can we start off, Commissioner Cook, could you introduce, and then we can go around to everyone and go from there, all right?
Absolutely. Well, thanks everyone for being here and thanks for having this meeting. I'm Commissioner Cook at the Department of Public Health. And I will turn it over to Elizabeth Denniston, who is up at EHS. We're just doing intros, right?
Yes.
Yeah.
Good afternoon, everybody. I'm Elizabeth Denniston, Undersecretary for Human Services at the Executive Office. And I'll pass it to Ruth.
Good afternoon. My name is Ruth Blodgett. I'm the Director for the Bureau of Community Health and Prevention, and the SANE program is within this Bureau. And I will hand it to Joan.
Thank you, Ruth. Hi, everyone. I'm Joan Sham, the Director of the SANE program for Massachusetts. And I will hand it to Dr. Garcia.
Hi, good afternoon. My name is Esteban Garcia. I'm the Chief Medical Officer for the Department of Public Health. I'm also a practicing pediatric emergency medicine physician, so bring a little different view on SANE, certainly. So thank you. Oh, and I'll pass it to, who did I miss? Rob.
How you doing? I'm Rob McLaughlin. I'm the Director of Legislative Affairs at Health and Human Services, and I'll kick it over to Tom.
Hi, I'm Tom Statuto, Deputy Legislative Director at Health and Human Services, and I will kick it over to Ryan.
Good morning, everybody. My name is Ryan McGeown-Conron. I'm the Acting Legislative Director here at the Department of Public Health. I'll kick it to Jen.
Hi, everybody. Jen Burrell, Deputy Commissioner for DPH. And I think last but never least, we'll send it over to Tori.
Good afternoon. I'm so sorry for having to be off camera. I'm Tori McNamara. I'm the Chief of Staff at the Department of Public Health. Thanks so much.
Thank you, everyone. And Sue from Cape Cod and the Islands, Commissioner on the Status of Women. Sue, can you jump in and do your intro?
Hi there, I'm on Nantucket, and I am the person who notified the Mass Commission. I'm a commissioner for the Cape Cod and Islands Commission on the Status of Women, and I apologize if my dog jumps into the picture.
Thank you, everyone. Thank you, everyone, for being here. As you know, with our letter that we sent out, when the MCSW, when the Mass Commission got the information from the Cape Cod and Islands, we then proceeded to reach out to speak to the Cape delegation to see what their thoughts were and what they were doing in regards to the SANE issue that was brought to our table in conversations with the Cape delegations. Then we had some conversation with the nurses in the region, in the area, contacted. So we did a variety of due diligence. I worked on Beacon Hill for quite a long time, and under State Representative Gloria Fox as her chief legislative aide for a long time. So I believe in due diligence and process and so on. So we reached out, we've talked to the sheriffs and so on in the area, the Cape delegation, elected officials, we've talked to the nurses. Then we had our meeting with Randy. I always pronunciate her name wrong, Petricone. Petricone. And that conversation went well, but it didn't give all of the answers that we really were looking for, because the women and girls and what impacts them in the Commonwealth of Massachusetts is why we were created. So we have a lot of women who have reached out and who have spoken to the Cape CSW and also to us, other than the electeds and so on, that are very concerned about where this might go. We've also talked to JDI. We've talked to a variety of other entities. We've had some conversations around what might happen or where it would go and how people view it. So why we asked if we can have a meeting with DPH to kind of understand, we saw in some of the letters that it was about retention and recruitment on why a decision was made, but we want to hear from DPH. We want to truly kind of like understand why this decision caused to us and all the work that we do, and hearings across the Commonwealth over the years and having conversations around sexual assault and other things, we're concerned about if this is happening in Cape and the Islands and we go telesane and we don't have in-person and we don't have that one-on-one, and is it going to be something that's going to be looked at later on? To some attorneys might say this is not done correctly. You might jeopardize the case.
Maybe,
so we're concerns. So,
absolutely.
yes.
And we appreciate those concerns, and we are so happy that you're meeting with us today, because I think we have a lot. I'm thrilled that you've done your due diligence and you've heard a lot of information. And I think maybe the piece that you're missing is the piece that we need to talk to you about. We know we're aligned in our vision. Obviously, we want to protect victims of sexual assault, all victims, women, girls, trans people, gay and lesbian and bi people. All the program is designed to help all of those people. So we want to talk a little bit about that. We want to talk about really the amazing service that Telesane provides, and that we believe it will be actually because of different factors that are happening in the Cape and Islands, we believe that that will be actually a better service actually for victims in that area. And we can explain why that is and how we have carefully considered this, both from the number of recruitment, like you talked about, Meredith, and also about the fact the number of sexual assaults that happen in this region and how those both factor into the decision that we made. So I again want to thank you all, and I hope that we can answer a lot of your questions and that we can at least have a productive conversation. You can understand how we came to this decision, because it certainly was well thought through. So I want to just turn it over to, I believe, Elizabeth Denniston, and she's going to go through some of the decision points that we touched on.
Great. Well, thank you, Commissioner. I do want to second the Commissioner's thoughts and saying we're really grateful to have this opportunity to talk through. I think all the questions that you raised in your letter are the right ones to be asking. And I think that I want to reiterate that this was a very deliberate, thoughtful decision. And I think the primary question that you raised in your letter was this a decision to provide quality trauma-informed care to survivors of sexual assault? And the answer is yes. And I am not the expert here, so I'm going to largely defer to Joan Sham and Dr. Garcia, who know a lot more than I do, but I'll just set the stage by talking through the key factors in making this decision. So staffing is a big piece of that, and I'll get to it. But the big thing about the Cape, as you know, it's the volume of sexual assault that they see in these two hospitals where there's 24/7 SANE. And I want to start by saying that there is going to be no cut to SANE. There's continuing to be 24/7 access to SANE at these hospitals. We are converting to a hybrid model such that from 9 to 3, the service will be in person, 9 to 3 during business days, and then the rest of the time there will be telesane access 24/7. So I think there's a commitment to quality care and 24/7 access, one. And so number two, the fact is the volume is very, very low at these two hospitals. Combined, they see 39 survivors a year. And it is our number one priority, regardless of numbers, to provide quality care. But that shakes out to about 3 people a month. And what that means is that the same nurses that do this are not getting the same level of experience as other regions. And they're not maintaining their experience and accreditation to the extent that we need for them to provide the trauma-informed care. So I think that even though staffing concerns is part of the decision, they're going to get a more experienced service provider and SANE nurse through telesane. And I'll let Joan speak to just the amount of experience and training that the telesane provider has. And so I know that you raised a lot of concerns around chain of evidence, sensitivity, and things like that. And we have a lot of experience with telesane that provides answers, that it's providing really, really quality care. We do it in 10 hospitals in Massachusetts. They've served 630 survivors. There's I know you mentioned or you referenced the article that reviewed it, and it's been really well reviewed and emulated throughout the country. And I think that we have I know that you raised the question about whether the survivor voice in providing telecine was heard. And I think that both Joan, Ruth, and Dr. Garcia can speak to that point, because I think they have a good answer. So I just want to reiterate that this was the right policy decision, regardless of staffing. And we are 100% committed to providing quality of care. And I think that we want this we can do a trial period with this and then reconvene and make sure that that's happening. So I think we're available to meet again. I do just want to touch on staffing, because this decision has to happen because of staffing too. And I think it's a reality that that nurses are way too hard to come by in the state of the Commonwealth and in the country right now. And the fact is that right now there are only 8 contracted SANEs on the Cape who are serving these 2 hospitals, where we would really need ideally 25. I think we could get by with 18 to 20. And so that's just a reality. And I just want to say that the SANE program and the Bureau and DPH has done everything they can to recruit qualified SANEs, and will continue to do so, and is working with the Legislative Caucus to do that. I hope you've heard. But it is a very intensive training program, and they do a lot of reference checks. It's a high bar, appropriately so, to become a SANE, and so it's hard to staff. So that's a long-winded way of saying, I really just want to reiterate that there's no better advocate for this. And it was a very, very carefully come by, deliberate decision by DPH, EHS, and the SANE program. And so with that, I'm going to really turn it over to the true experts, with Joan Sham, who runs the program, and Dr. Garcia, who just has a lot of experience with it.
Thank you, Undersecretary. Just to reiterate, we have been doing this for 10 years. We really feel that this is a trauma-informed and quality model for sexual assault patients. We've had very high acceptance rates of 96%. When we started this, we weren't sure what that was going to be like, because obviously patients are traumatized. And we were, really happily surprised that 96% of patients accepted it. It is a very intimate experience, and people feel like they're in the room, and they'll talk like they're all in the room together. So even though it's across a computer screen, it feels very intimate. The Lieutenant Governor came to the center to see it, and that was her response is, wow, I feel like I'm in the room. And we welcome you to come to the center at any time if you would like to come to be there. But we really modeled this very carefully after our in-person program. We have rape crisis available on site with the nurse who is caring for the patient, and the patient always has a nurse there in the room with them. So in addition to the telesane who is there for the entire encounter, which is usually about 3 hours, the nurse from the hospital is also there, as well as the rape crisis advocate. And so it has been a very positive experience for the patients, and we have cared for the past couple of weeks, a few more. So 644 patients have received our services over the past 10 years. And, it's just been a very quality model. As Undersecretary Dennison said, these are our most experienced SANE nurses. So they have all done in-person SANE, and many of them have 10 years of experience being SANE nurses. So we take that very carefully when we choose them. We also provide them training on how you provide compassionate care over a computer screen, and how do you do that, and how do you support that nurse? And our real philosophy going forward was, we don't want to take over for the nurse, we want to raise them up. And we work closely with them as a team. Before we meet with the patient, the nurse and the telesane come together. They talk about what the patient's experience is, what the nurse knows about the patient, and how they can best work together. The telesane also asks the hospital nurse, what is your level of comfort? You know, we are doing baseline training with them, but some of them have cared for sexual assault patients, and some of them have done many kits and some have not. And so we really get a sense from that nurse of how can we best support you and hold you up in front of your patient. So it really is a team approach, and it's, you know, 2 brains in the room instead of 1. So it's, you know, it's actually adding some extra, you know, brain power to the room, because now you have 2 nurses in the room that are problem solving and thinking about how best to meet this patient's needs. So again, we just feel very confident that because of all the factors, especially around the volume on the Cape, and to bring on 20 nurses, which is what we really need to have nurses work about 24 to 36 hours of on-call a month, to train those 20 nurses with 39 patients and to keep them competent and confident is really going to be problematic. And so this way you're always getting 100% response of a experienced expert SANE nurse.
And I'll just jump in. So, you know, my experience as a pediatric emergency medicine doc is even the number of children that we see in these situations. So I was and have been a kind of a SANE provider in pediatrics. We do that in the emergency department, and so few of the cases that we get as physicians, you know, we work alongside our nurses, and certainly you know, I come from the South, I've come from Texas, and the ability to have an expert with you. I mean, I felt as an individual provider that you know, was I really the best person to be doing this in pediatrics when I was doing it, understanding that I did maybe 3 or 4, and then I was the expert. That's the way we, back in the day, the way we did this. And so it's a much better system having the SANE program to really support the individuals that are at the bedside and provide that, as Joan said, I can't say it enough, the extra set of eyes and the extra brain is really helpful in these settings to do everything the right way, to follow the kit that you know, and make sure that you're collecting and keeping the chain of custody where it needs to be, and that does make a huge difference. And I think having the support of TeleSANE is going to be really important because of the volume. And I think that's a fair clinical concern. And as a clinician, I think we want to make sure that we have an appropriate volume to maintain our competencies. And it's something that our SANE nurses, if their volume is very low, then we are concerned. And I think as a clinician, that's a concern I have. I will tell you that I was at Cooley Dickinson as their chief medical officer prior to joining DPH. And one of my concerns at a rural, semi-rural community hospital was whether or not my clinicians, all of them, including nursing staff, had the ability to maintain skills when the volume was so low in certain areas. And so different than SANE, clearly, but we still had some concerns about clinicians and had to figure out how do we get them to a competency sustaining volume. So that's something else that does worry me as a clinician, I think, in this setting. And then I'll tell you that from the South, you know, the University of Arkansas has a great program of TeleSANE, and you know, certainly is a program that I had heard much of, and continue to be impressed by the work that they had done. And then I learned about our program when I joined DPH, and knew, of course, about the SANE providers. And then the fact that our TeleSANE program, you know, it didn't come about because of the pandemic, to be clear, right? We have years of experience here as a leader. When I went to look for published work, it was interesting that, you know, Joan's name was there and other names that from our state. It does your heart good to know that your state is also helping to fill in the gaps in the research here and the good work that we are doing as a state. And then the last thing I'll say is that, you know, many of our remote areas certainly do TeleSANE in other states. And I know we're looking at partnering with states, and Joan can speak to that. But, you know, Alaska, I was in Seattle before moving to New York and then to Massachusetts, and certainly reaching those areas with SANE capabilities is a real challenge in kind of the remote areas of Alaska, and became a very good program to support those areas as well. So it's a very common. And I think from a scientific clinical perspective, I'm not concerned at all that we're not meeting the clinical expertise that needs to happen, or concerned at all that the you know, the concerns that have been raised about the chain of custody and other things, I think are misguided and don't have any clinical weight to support those concerns from my perspective. So
okay,
thank you.
Doc. Sorry, thank you, Doctor. So so here's a couple of questions from the MCSW that we would help us also just after hearing what everyone said. So first and foremost, we understand that when you go to the telesane, and we understand you're going to have an in-person, but from what we are being told, it's going to be like one person on call per diem for that in-person time, and not the 11 or the 8 that we were told. So the coverage there is the concern. So go ahead.
Oh, I'm sorry.
Yeah.
If you weren't done, I'm happy to let you finish before.
Yeah, go ahead, and I'll go to the next one. Go ahead.
So basically for the hybrid, for the in-person, it's going to be one of our DPH staff members, the person who is currently the regional coordinator. So she will be available Monday through Friday, 9 to 3 to provide coverage. Even though we have 9 SANEs on the Cape, there's only one person on call at a time. So those 9 people wouldn't be on during that time in general. So it is not lessening the availability of the SANE. There's still going to be one person available. It will just be one of our staff members instead of one of the on-call nurses, if that makes sense.
Okay, so the regional Kathleen, Kathleen, is it the name? I think we spoke with. Yes. So okay, and then Ms. Randy said that you do a 6-hour training with the ER departments. So our question was, if you were able to do that 6-hour training, which we're not doctors, we're not clinicians, and but if these nurses, the ER nurses, are already overwhelmed over time, and now we're asking them to take on a 3 to 4 hour patient on their roster. How can we work with these ER departments? And it's just something we came up with after we talked to Randy and we listened to the nurses and so on. These nurses that are not SANE certified get the 6-hour training. Is there a way that they can do training and be SANE certified, and that way they'll be nurses, ER nurses that work in these facilities that are SANE certified in case there is a sexual assault survivor there that they need? So can we kind of overlap the training of these? Because in our conversations around this piece of it, the Cape delegation says, well, the community college down here has the space where we can do training, we can do whatever. So that was something that was brought to the table. Is that something that was thought about, if maybe we'd be able to, other than just doing the 6-hour training, doing a little more training to get nurses certified?
Well, the training is a 48-hour training. It's a pretty intensive training to become a SANE. And quite honestly, not every nurse wants to be a SANE or a forensic nurse and be caring for patients all the time who have these challenges. And can be, emotional and stressful. The training that we are providing are for the hospital clinicians in trauma-informed care, the basics of forensic evidence collection, and how to use the equipment. So it's very different training, but we are trying to put forward some very important principles of trauma-informed care that they then can take to all of the rest of their patients, because everyone should have trauma-informed care in the emergency department. So it's a very different type of training that we're providing, and a very different kind of commitment for somebody who wants to be a SANE nurse and be, caring for multiple patients. So it's quite different. And for the past 3 years, it used to be a 6-day training in person in Worcester. For the past 3 years, it has been a hybrid training where the vast majority is done virtually with live lectures that are multidisciplinary. So we have the DAs there, we have the crime lab, we have rape crisis. So it involves a lot of coordination of different presenters. So some of it is pre-reading and some of it is live. And then there are 2 days that we hold at UMass Medical School in Worcester. So nurses come from all over the state, from Pittsfield, from the North Shore, from the Cape, to do these 2 days. And in these 2 days, we have what we call standardized patient models. So they're actually volunteers who allow themselves to have speculum exams. So the nurses get to do the clinical training in real time. They practice with the evidence collection kit. So it's really critical hands-on training that they get at UMass. And it's hard enough trying to get, space there and getting the appropriate facilities and having access to these medical models. It is quite an undertaking, and it's why we do the training twice a year. So it isn't something we could just do on the Cape. And, it's just a much more complicated process. And the expectations to stay a SANE, require some attendance at staff meetings, some quality assurance on their work. So it is a process that we take very seriously. And the expectation and the level, and to be honest, we interview SANE nurses because sometimes, they may want to do it, but people may think it's like CSI, which it is not. It's very different than that. And sometimes people, when we get 3 references, sometimes the references may not think that they have the best interpersonal skills or whatever to be a SANE. So we do an interview and we take that very seriously and make sure if somebody is a survivor, that they're in the place of their healing, that this is a good place for them to be doing this kind of work. So it isn't
Joan,
that simple.
The other piece I would add is just the concern about the ongoing clinical competency. And I think that, first of all, training folks to become SANE, training nurses to become SANE nurses is all of what Joan talked about. And even the hands-on piece with the model patient is, again, you only want to put somebody through that, even if they're volunteering, in a way that makes sense and is going to lead to a SANE practitioner that will be clinically competent moving forward. So it really is pretty invasive, and I would want to make sure that I would still be worried that the nurses, if we're doing 3 a month between 6 nurses at Cape Cod Healthcare, that they would be able to maintain competencies, because I think it would be very difficult also.
Thank you both for that, because that leads to the next question. Our concern, and we said it to Ms. Randy when we met with her, that ER nurses are trained. They have that competency, cultural, that trauma, and so on, but not everyone is ready and fit to be a trauma care nurse for sexual assaults, or even if it's a youth sexual assault, to LGBTQ and trans. So we were concerned about the compassion and the competency of that care that ER nurse, excuse me, would be offering, even though there is a telesane nurse on the screen. It's not the same. You can't, because not everybody can do that. And as a woman and a commissioner, we have to bring these topics to the table, because I've experienced, even just in a regular OBGYN appointment with some doctors, very uncomfortable, not, so we have to think about, so we have to ask these questions. So that's why we were asking about the training, asking about, is this the right fit? And we hear you, but here's one of the things that you guys don't hear, that like we hear when we go out to hearings in person, or as we've been doing virtually. We get a lot of women who come to us and are concerned about where they live. So for example, when we do hearings in Cape and the Islands area, when we do hearings in Great Barrington and certain rural communities, Pittsfield, as we're going to be doing next month, we hear a lot about that. We're invisible. We're always pushed to the back. We don't get the same care as all of the other urban communities, all of the bigger cities, and because we're a small town and so on. So that's the concern that we also have now, because Cape and the Islands was feeling, the women that we were talking to were feeling that this was something that was coming down because of their rural community and where they're at, and there's not high, assaults and so on. So these are things that, we are we're asking these other questions to kind of come back with the answer, because the women and the girls of the Commonwealth are going to expect us to come out with a final statement, a final something after we do all of this, to kind of make them understand and be comfortable with DPH's decision, right? So that's why we're asking about the trainings and the competency and the excuse me, the trauma and everything that's going on with this. And again, we've had conversations with the MNA in the area, with the nurses in that area. And even the nurses are asking us, how is this gonna impact our community? Not just as a nurse, but as a woman that would go in for the care. So that's something we're concerned on. Can Joan, Dr. Garcia, love your passion. I'm loving your answers, but they hold us to the fire a little more than they, so we have to, ask those hard questions, and my sister, Sarah, who's on here, she works with the deaf community, and those are, when we had a conversation, some of the questions that came from them was, okay, how is this going to be for us in our community? If we have a survivor come in and they're from within the deaf community, now we have, so now we have interpretation as to all these different things that's going to impact that that exam. So many things, yeah.
I mean, we have worked with deaf patients. We've also worked with patients who English is not their first language, and the hospitals bring in translation services just like they would in person. We also have seen in a lot of the hospitals that there is often a group of nurses who are gravitating towards this, and they are the ones who are saying, I would really like to do this. And so obviously that is who we would like to engage with at first, and we try to make those efforts to do so. We totally understand what you are saying. I'd also like to say that, a lot of what we do in that team building and that pre-encounter is really talking to that nurse about how, we can work together, and the Telesane really models this trauma-informed approach with that nurse, and so can take the lead if the nurse is a little bit more hesitant. So we really have thought of these things. Our number one priority is patients and survivors. And, we didn't enter into this lightly. We really put a lot of thought into this. And again, as Dr. Garcia said, having this model replicated nationally. You may not know Dr. Garcia, but we're actually providing TA to technical assistants to the University of Arkansas, as well as Alaska, South Dakota, and Texas. So, we are having our model be replicated. And I don't know if you have seen our article, I think Randy sent it to you, but our quality caring model, where really that's what we're trying to do, is provide quality care. And we developed the model that is being replicated nationally. And the focus is first on the patient, but also supporting that nurse and how we work with that nurse to hold them up. And that's what I do, is team build and support that nurse.
And I just want to echo, I don't want to take up too much time, but echo what Joan said. The idea, so in a clinical practice, in the emergency department, right, you do have your nurses, and quite frankly, if you have more than one provider, you may have providers that gravitate towards wanting to be involved in taking care of these patients, and others that maybe, would have different, feel like insecure about their abilities and maybe, maybe have their own trauma issues, right? That is possible with our nurses, certainly, and don't want to be in this situation. We are very good about making sure that there's somebody available that will then assume responsibility and be the person. It may be the nurse that comes from another pod. It may be the nurse that stays over at the end of the shift because they said, I really want to be the one. I started this. The nurses don't leave when their shifts are over if they're involved in one of these cases. So I do think that that's just a normal kind of clinical approach, is that you have people who gravitate and are interested, and we will train, and certainly they'll be the go-tos, which I think is great. And then they tend to then help and support their colleagues to get more comfortable with the process of what they're going through. So I don't think there will be an issue where you'll have a nurse that really doesn't want to be there and is put into a situation. I think we would do everything we could to help support them through this, in real time. So.
Okay, so here's a hard question. Can we ask for a 6-month follow-up, like give it the time, or have you guys looked at what you might call a trial session for you, and when you would look again to see if this is working well? Excuse me. Wow. And just a thought, because I'd like to be able to or the MCSW, when I say I mean us as an entity, would like to be able to say, okay, let's come back and see how this is looking, what's going on. So we can also follow up Cape delegation, we can follow up the MNA and that region, JDI, and see if we're all, you know, if this is a good fit. I know you guys say it's a good fit, you researched it, but again, we're not clinicians, we're not doctors. We just work with the women and girls and try to do as much as we can to improve lives for them here in the Commonwealth. And this is good because we can learn and we can learn much. And now that you've mentioned Alaska and Arizona and all of those, in my other hat, president of the National Association of Commissions for Women. So now I'm going to reach out to my sisters and say, hey, what's happening in your state with Telesane and so on? Can you give me some input, some information? You know, we have a convening coming up on next Monday. So I'm going to be like, hey, do you guys know about this? What's going on? You tell me what's happening in your state so I can get a little bit of, you know, feedback from there also. But is there a trial date that you're looking at, or can we ask for a trial date? Joan, everybody's keeps scritching around.
I know everyone's moving around.
Yeah.
I think it's great to reach out to those states, just so you know their programs are younger. They have grant and they've been in the grant for a couple of years, so they're not as experienced as we are. I assume you're talking about doing a pilot. I mean, we feel like we need to move forward on November 14th with Telesane because nothing has changed around staffing and volume. And then coming back to talk about that, is that what I understand?
Yeah, so if you're doing, can we come back, talk, see how it's going? I know the Cape delegation had asked if you could wait till the spring, till the next training session, and you guys had already said no on that one. So just trying to see how we can come back and revisit this to see where we're at. If that's something you were looking to do, or I know you didn't want to, but you know, can we ask for that?
Well, I think we want to be transparent about everything that we do, and we are holding up survivors and patients in the same way that you are. You know, I don't know why we couldn't reconvene and talk about, you know, how things are going.
Yeah. Okay. Thank you. Yeah, because every report that we've seen, you know, we really hadn't seen too much of questions to survivors and how they felt and how the program was running. So at least this way, the ones that the women that are on the ground in the Cape and the Islands, if they're hearing feedback and if they're being contacted, so now we can also kind of work from that, you know, from what the sisters are sharing with us in that area, you know, and we'd like to be able to, if we can, come back and reconvene 6 months or something or whatever. You know?
And Dr. Garcia spoke to a point that I would just like to reiterate, and that's the concerns that have been raised about chain of custody. They are not valid. And the more that they're put out there, the more potential harm that is causing to patients who have had Telesane services, who at some point may go to trial. You know, putting those issues out there when they are not valid is really harmful. So, you know, again, the chain of custody and protocols are identical to what we do in person. There is a nurse in the room with the patient and the forensic evidence the entire time, maybe an advocate, and our Telesane has a bird's eye view of the room and watches that evidence. The evidence is packaged and sealed. It either is handed over directly to a law enforcement or it is put into a locked refrigerator following protocol. And then it's also put into the state's newer track system. So, you know, I think it's just really important that you all understand that those are not valid concerns and potentially harmful concerns the more that they are raised in public, because that is causing us concern for patients or patients who may not come forward because of their hearing that. I mean, it's hard enough now for patients to come forward, and we know how few of these cases go forward to prosecution. So to have something else potentially impact the prosecution is really concerning to us.
Thank you for that. Yeah, and we asked that question because that was something that was brought to us in a variety of different ways. A couple of different people asked that question. So we had to ask that question. I do know we have a new vault and new process because I was still working on the Hill when we put that into play. but at the same time, it's come to us, we have to ask those hard questions. So thank you for that answer, and we'll do that. And what we're going to do after this meeting, we're going to sit back down with the full committee, and we're going to make our statement that we're going to put out that talks about all that we've learned and where we are. And if we agree on this convening in 6 months, that we'll come back and visit in 6 months to you know, just touch bases on what's happening with the hybrid program, you know, and go from there. We just don't want to, we didn't want to put anything out there that wasn't factual. So these meetings helped us so much with a lot of information, a lot of knowledge. Sister Sarah, is there anything you want to add that we need to ask? I'm watching the clock and I don't want to hold everybody too much.
No, I think you covered it.
Thank you so much.
May I make an offer or offer/suggestion? I'm thinking about how much misinformation has been out there as part of this process and how complex this whole program is. And given the sophistication and the care and consideration that the SANE nurses and the team provide to make sure that we offer high quality services, whether it be in person or telesane, that both are designed with the patient in mind, as you've heard. And my offer and request would be, would love to take a look at what you write up before you issue it to make sure that there isn't some misinformation in there that will further make this more complicated for folks. And I think we want to make sure everything we do is in responsibility to the patients, and we want to make sure people are really comfortable coming forward when they've had a sexual assault so they can get the care they need. And so many people are still not comfortable coming forward. So I think we want to be very sensitive about that, as well as thoughtful about the not inadvertently making, there, as Joan said, very few cases actually go to trial, and we don't want to do anything that minimizes or further compromises that. And there are so many, there's such a big context here that is all part of the design of this that I think gets lost sometimes in this specific staffing issue. So, Joan and her team are paying attention to the service for the entire Commonwealth. Mm-hmm. And I think we want anything that happens as a result of the conversations in the Cape affect every woman and person that might have a sexual assault case. And I think we want to be just really, really responsible about our potential, any inadvertent impact. So that was a long-winded request.
Yeah, that was very, and I thank you for that, and I appreciate you. And I'm going to look at my ED and my chair, and I'm going to behave. And I'm going to say that we are not. Typically, we are not irresponsible. We don't put out negative. The letter that you received only came to your office, only came to you. And all the information that you see in our letter came from our public hearing down in Provincetown. You can get the link and listen to it. And you can hear what people said to us and what put forth questions to us. And that's where we put our questions into our letter that we sent out. Nothing that we put in there came from us directly, came from others out there. And our enabling language says that we should listen to and hear what the women and girls in the Commonwealth of Massachusetts are saying to us. And we have that right to go and find the truth to give them an answer. So this is what we're doing, due diligence to give them an answer. So Ms. Ruth, I thank you for that question, but the MCSW has never, when we write our statements and our letters to go out, have gone outside of the commission to allow anyone to proof or pencil our statements. And we don't even let our appointing authorities, the governor, the speaker, the secretary, Speaker of the House, the Senate President, or the Women's Legislative Caucus tell us what to put in our statements. So I apologize. I don't think I'm gonna let you look at our statement to tell us if we are lying or telling the truth or whatever. But I can say to you that we will release it to you first and then release it to the public. Right?
And we totally respect that. And we have a lot of faith in we really, really appreciate your listening, your sensitivity to survivors, you're coming to this with an open mind and asking the right questions and being an incredible advocate. And we very much respect your independence and need to do that. I think that the question came from making sure that it is very sensitive to survivors and wouldn't ever deter someone from seeking care. And we know that wouldn't be the case, and just want to make that very clear. So we're really grateful for your time. Any other follow-up questions, we would love to take you up on the offer to reconvene in 6 months. Because I think the feedback that you're hearing may not be the same as we're hearing. And so it would be great to compare notes.
Yes, definitely. Because I know it's not. And that's where, you know, most of you have the sun directly, and I'm going to get ready to go get you off so you don't have to. But again, we'll definitely release it to your office, under Secretary Commissioner Cook's office, the Secretary's office, and that way you guys will be able to get it before Ms. Sham. It'll come to you, and also to Randy. So the initials that we started from, those are the ones that'll get it. And you'll be able to see it. We'll give you 24 hours before we release it out to the public. We typically try to do that process. Yeah, and then we can go from there, because our respect to the DPH, our respect to the Commonwealth, we're here to just focus on women and girls and all, you know, make it better for everybody, right? So thank you so much for your time. And if there's anything that you would like to share with us, if there's some notes or something you think that you want to send us, that we could look at to put in our statement. Our goal, we have a meeting coming up, and then we'll be able to look at everything before so the statement might not come out till like the beginning of November. But if there's something you want to share it with Shalea and Shaitia's email, and they'll get it back to us in policy. All right.
Great.
Thank you so much. You guys have a blessed week. Be safe.
Thank you.
All right.
Thank you so much.
Thank you.
Thank you.
Shai, where you at? Oh, there you are. Shalea. Oh.
Are we all set to stop recording?
Yeah.